Hey, hello everyone. My name is Sandra Alexander, and I am the project manager for Circular Clinical Care, which is a project by the Canadian Coalition for Green Healthcare being undertaken with the financial support of Environment and Climate Change Canada. And on behalf of the team, I would like to welcome you today to our fourth webinar for Plastics Reduction Week, focused on opportunities to reduce single-use plastic related to packaging in healthcare. And we will particularly be emphasizing pharmaceutical packaging today. We have such a diverse audience representing various hospital departments across Canada's 10 provinces and across numerous countries, which to our team really highlights the interdisciplinary commitment to collaboratively reducing waste that exists in the sector. So while our team does acknowledge that plastics play an important role in safety for patients, clinicians, and it's also important for infection control, we do believe there are various opportunities to promote a circular economy and more resilient supply chains without compromising safety or the quality of patient care. So during this webinar, we will be exploring the exponential growth of single-use plastic waste generated by the healthcare sector, which led to the launch of the Circular Clinical Care Single-Use Plastics Reduction Project. And after laying the foundational context, we will dive into specific actionable projects, starting with Dr. Bavini, who will be speaking about implementing a project related to direct IV pushes for ketorolac at Alberta Health Services. Then moving on to my research associate, Tipu, who will be speaking about our project's work, where we are exploring other medications that we could administer through direct IV pushes before switching over to dialysis, looking at our work. Our coalition team member, William, has been exploring with Unity Health in Toronto related to dialysis. And then switching back to Tipu, where we discuss a promising project that our team would like to find a pilot site for to implement regarding reusable glass vials for pharmacies. And then we will end off the conversation today by talking about the environmental impact of switching away from using sterile water bottles to using tap water in non-sterile endoscopy procedures. So we have a packed agenda today, the pun is intended, and we're very excited to dive into these solutions with you. And we do encourage you to ask your questions and put your ideas throughout the session using the chat and Q&A functions. So with that, let's get started. So as a project manager, I like to start by defining the problem, defining what plastic is, because the magnitude of these synthetic materials in the healthcare sector is outstanding. Why? Because plastic is such a broad umbrella term that the diversity of what their polymer composition is allows them to be malleable and versatile. And versatility is incredibly valuable in healthcare. And plastics offer exactly that. They're materials that can be shaped, they can be sterilized, and they can be used safely across a vast range of clinical tasks. Plus, plastic itself is a low-cost material, and with healthcare systems across the country feeling overwhelmed, often due to limited budgets but growing needs, plastic materials are a highly attractive option. And the effect of all of this is compounded when we actually look at the history of clinical practice and the way procedures have been done over the years. One-time plastic use is embedded into behavior because it's often associated with sterility. And that association itself can be accredited, at least like to some degree, as to why healthcare sector use more virgin plastics than any other sector. So when we look at where plastic exists in healthcare, they're virtually everywhere from packaging to devices to the items that are worn, to some specialized coatings of pills that patients take, and even the acrylic or latex-based paint on hospital walls could contain plastic. And so the list goes on, and by extension, the waste keeps piling and piling. It has piled up to the point where in 2023, across Europe and North America, there was a total system emissions of 9.3 million tons of carbon dioxide equivalent just from single-use healthcare plastic. And Eunomia and System IQ just released a report this year titled Prescription for Change. And this report is the first of its kind, exploring the global depth of this problem. And it really focuses on advancing the circular economy by providing a roadmap of evidence-based strategies for change. And the reason why this report has become such a prominent part of the conversation so quickly is because they project that without urgent action, hospitals across the United States and Canada could reach 3.6 million tons of carbon dioxide equivalent per year in 2040. And in 2040, they could be facing up to $37 billion each year in plastic waste management costs, which is a 28% increase over today's expenses. So not only is it costing the environment, but it's also costing a significant amount of money that could be diverted to providing direct patient care or infrastructure support. And the costs continue to rise because the environmental output is actively accelerating global carbon pricing, which then requires tighter climate regulations. And for transparency, the Circular Clinical Care Project Advisor and myself, the project manager, are listed as contributors to this report, as we did provide insight into the Canadian landscape using data from previous and current projects at the Canadian Coalition for Green Healthcare. And this message can be further reinforced through The Lancet that has published papers this year with the same message that single-use plastic waste in healthcare is a topic of urgent concern. Continuously highlighting that plastic pollution is caused by human activity and that there are human health risks at every stage of the plastic life cycle. And this is why matter matters, because less than 10% of this matter is recycled. And essentially, all of the actionable steps and future research goes back to the need for interdisciplinary action. To give you some numbers from papers published this year in 2025, globally, the healthcare sector disposes of 16 billion plastic syringes and 15 billion face masks. In 2020, a report from the University of British Columbia gave a general estimate that plastics account for approximately 30% of all waste in Canadian healthcare systems, which all of this is to further emphasize there is a need for change. When we zoom into the plastics, there are over 13,000 monomers, and more than 3,000 of them are of concern to human health, according to the United Nations Environmental Program. These chemicals of concern, however, are translated into the medical devices that we have that are directly used to provide patient care or to treat medical conditions, like using implanted devices. But whether the plastic is directly introduced into the body system or indirectly, microplastics and nanoplastics will find their way in. They have been found throughout the human body, and we are starting to learn that they can cross the placenta and the blood-brain barriers and basically start to influence all of the major physiological systems. Food and water have been thought to be the main path of exposure, but new evidence is highlighting that they could just also be inhaled through air pollution. Recent studies have shown that we inhale up to 68,000 plastic particles per day, which equates to the average person having 7 grams of microplastics in their body. So when we multiply 7 grams by Canada's population, which was estimated at 41.4 million people in 2024, the math shows us that the human bodies of the people living in Canada are essentially vessels that are carrying a combined weight of 290,000 100,000 kilograms of microplastics. And so that is why we need to take action. So recognizing this problem, this led to the launch of the Circular Clinical Care Project, which is a 3-year project being undertaken with the financial support of Environment and Climate Change Canada, where we aim to reduce single-use plastic waste in healthcare across 4 areas that we have identified as hotspots, which align with the themes of Plastics Reduction Week. So today we are focusing on pharmaceutical packaging, and tomorrow will be perioperative care. And we have 3 partners for this project. Our pilot partner is Hamilton Health Sciences, which is a network of hospitals in Hamilton, Ontario, Canada. And it is the only hospital system in Ontario that cares for all ages from pre-birth to end of life. And they are a world-renowned hospital for healthcare research, which is correlated to their collaborative relationship with McMaster University, especially with the School of Medicine, which is a full project-long partner of the Circular Clinical Care Project. Within the School of Medicine, we have partnered with McMaster University's postgraduate medical education, which is a program where our executive director, Dr. Sargent, leads the sustainability stream. And we collaborate with medical residents to implement quality improvement projects in the hospital. And just for clarity, a resident has their medical degree, but they are now training into their specialties. And lastly, we also have a project-long relationship with Peach Health Ontario, which is a collaborative group based in McMaster University, but their work spans across Ontario, and they support our knowledge translation work. And so at this point, we are 12 months into the project and starting to transition to a national campaign. And we have the pleasure of learning so much so quickly from healthcare sustainability champions across Canada, like Dr. Bavini from Alberta Health Services, who will now speak about her team's work at implementing direct IV pushes for ketorolac.
Thank you, Sandra. I'm just going to share my screen. Wonderful. Well, thank you so much for having me come and speak today. Really appreciate it. I'm going to be talking about a project that we actually implemented at one of our sites in Alberta at South Health Campus. This is one of our hospitals in the Calgary zone, which is called Thinking Outside the Bag. We actually use the quality improvement framework to actually facilitate this project. And since then has seen widespread uptake and scaling across the actual province. So this project is thinking outside the bag. It's our ketorolac project. So ketorolac is a pain medication that we often give in emergency. And typically we actually use an IV mini bag to actually administer the drug. And so the emergency department wanted to look at ways to make things a little bit more efficient. So rather than actually put the pain medication in the mini bag, they said, well, how about we actually push it? Now, the great thing about ketorolac is, unlike certain medications, the push of a medication sometimes has to be done over a certain amount of time. So, for instance, like 5 minutes, whereas ketorolac can be given fairly quickly through direct IV administration. So, they implemented this across our emergency medicine department at South Health Campus. And what they found was that there were a significant reduction in IV mini bags used. So when we reported out our outcomes, what we did find was that patients actually received the pain medication quicker, which is important for pain management, and actually reduced the medication onset time by approximately 19 minutes. This also had significant carbon savings, so about 1,272 kilograms of CO2 per year, which is equivalent equivalent to driving approximately 5,000 kilometers in a car. And then there were significant cost savings because we were not using mini bags, so about $23,000 per year from not actually using mini bags. What was actually really interesting and what captured the operations eye with this project was the actual nursing hours, a time saved per month. So we were saving about 24 hours of nursing time that could be redirected to higher value of patient care activities. And in a time where emergency departments are struggling with flow of patient, not having patients sort of hooked up to a pole meant that we eliminated the IV pole and we could actually improve the patient experience, reduce the sense of restriction of mobility, and move patients around in our emergency department as well. So this project was quite successful. One of the things that we did have to implement, there was a significant change that had to happen. The emergency medicine team are very used to pushing drugs, but it was really the EMR system. So we're actually on Epic, and there had to be some local changes that needed to happen through Epic in order for us to actually implement this change. So rather than ordering it as an IV mini bag, we actually had to change the order completely in our Epic system to direct. The good thing is that that was able to occur locally rather than provincially, so we could actually move ahead with this project. So having engagement with our IT and Epic team was actually crucial in actually making this project a success. So with that, we thought, well, let's look at this for other medications. And so as well, currently we're restructuring in Alberta, but we actually have multiple acute care emergency departments across the province. So when we actually looked at the cost savings, if we were to implement this across all the different sites, we actually found that there was a savings of about $288,000. And then we looked at the common used antibiotic, which was ceftriaxone. And if we actually implemented this with ceftriaxone, again, across all of our different sites across the province, there was a cost savings of about $750,000. What we did actually find is ceftriaxone, with the way that it's with the way that we actually receive the vials, we actually found that it was probably not the best medication to actually use because we already had significant sort of environmental impact reduction with the way that how ceftriaxone is coming to us it's not coming in to us in small vials, it comes us in larger vials with 10 doses, so it made it more challenging. So now we're looking at the common used agent that we use to treat heart failure, which is furosemide and Lasix. So some of the opportunities that we have seen is that we've been able to spread this to other medications such as furosemide. And then there's obviously been thoughts about ceftriaxone in the past, because we know there are many drugs that we can actually push. The opportunities have been great because we've had engagement from nursing staff. And when they see that 24 hours in nursing time saved and moving over to other high valued care, there was a significant amount of engagement from nursing time saying, actually, this is much quicker. I don't have to worry about finding a pole and I can push the drug. It also saved pharmacy time because typically pharmacy actually prepare the IV mini bag. So not having to prepare that and just send up the drug actually saved, again, time for pharmacy, but that actually wasn't captured in the project. But we're hoping that's something that will be looked at as we spread and scale. There were significant changes needed. I think some of the challenge we faced is, okay, we were able to do this in our electronic medical record system. But, trying to do this provincially is going to require actually a lot more engagement. So I think that's going to be a hurdle that we're going to have to deal with. And then tracking data. What was actually very interesting is that, even though it's hard to say that the drug was actually given, IV direct, or whether they were still using IV mini bags, and sometimes pharmacy was still drawing up IV mini bags. So that was very difficult to track in our Epic system as well. Not only are we looking at sort of implementing this in the emerge department, but we looked at our inpatient units. And one one of the things that actually came up is that a lot of our nursing staff aren't trained to actually push drugs on our inpatient units. So we know there's going to need to be a significant amount of education done by the clinical nurse educators to actually train nurses up in doing IV push. So we know that if we need to spread and scale, there's going to be huge sort of training that's required on all of our inpatient units at South Health Campus. So right now, this is a project that is really being looked at across our Calgary zone, but there is significant opportunities here to spread and scale. And of course, cost savings, carbon footprint, and less waste as well. So I'll stop there. Thank you.
Thank you, Dr. Goel, for sharing such an innovative sustainability initiative. It was also inspiring to hear about Alberta Health Services leadership and success, especially at the 2025 Sustainable Quality Improvement Showcase in the UK. And it's such a pleasure to virtually meet you all. My name is Tipu, and I'm a research associate at the Coalition. I have an academic background in interdisciplinary science, clinical research, and global health. And today I'm excited to share our work on identifying and quantifying the environmental impact of direct IV push practices, and then shift into discussing the potential of reusable pharmaceutical vials as a plastic reduction initiative in medication packaging later in today's session. Um, Alberta Health Services' 25% reduction in mini bag orders, as shown in the figure on the bottom right of the slide, is a significant indicator of reduced single-use plastic waste. And this success led us to explore how we might scale the innovation across other Canadian healthcare sites. And we conducted a brief scan across our network and found that several facilities were already using IV pushes in certain clinical situations, often in response to supply chain disruptions. And so that told us that there already is some organic adoption. And to begin quantifying the impact in a way that could be sort of standardized and replicated across sites, we turned to the medical literature to understand what an IV setup involves. That's where this diagram comes from, the one on the left, directly from a open source medical textbook, and then to analyze the plastics composition of each of these components that are typically used. And from there, we mapped which one of those items could be completely avoided when switching to a direct IV push method. And while still in the process of validating assumptions, both our review of the academic literature and our conversations with frontline staff suggest that everything highlighted in peach on this diagram represents consumption, much of it being single-use plastics that can be fully eliminated through a push. And we also explored the potential to use direct IV push when a patient might already be tethered to an IV setup, such as during longer inpatient stays, to ensure the approach remains practical and safe across this broader range of scenarios. And in these cases, where the patient is already tethered to an IV setup, and pending further clinical validation, there still appears to be an opportunity to reduce at least some single-use plastic waste, as is highlighted on this figure, by minimizing the use of secondary bags and perhaps tubing. Reducing even a single IV bag represents a meaningful step, particularly in the light of findings such as those in Pardeschi and colleagues' 2017 study, which showed the presence of microplastics suspended in IV fluids that were packaged in plastic IV bags. And so for our next steps, we are collaborating with a clinical pharmacist at our pilot site to analyze the impact of direct IV push for antibiotics, such as cefazolin. We are also working on generating a list of medications that can be pushed feasibly and viably and holistically across multiple sites and can be scaled nationally. And we're developing a business case while assessing clinical labor impacts. We're also grounding our approach in evidence, such as ensuring that we consider the dosing pathway and consult with clinicians and pharmacists about the implications of pushes to transparently map and identify patient safety concerns. And with that, I will pass the floor to Will.
Thank you so much, Tipu. It's really great to be here. And thanks, Sandra, for leading this really fun week of plastics reduction. I think it's just so cool to see this on LinkedIn and on socials. And I think it's great that we're bringing attention to this topic. And I will share my slides here. And I'll make sure to share the sound as well. Can I get a thumbs up if you see this? Well, great. Thanks so much. So I'm not a nephrologist and I'm not a physician. I'm a building engineer and I'm currently doing a PhD on decarbonizing healthcare systems. But I want to share a story here of greener nephrology at St. Michael's Hospital in Ontario because I think it's a really, really good one. And initially we tried to have a clinician to present this, but somehow I ended up with being on this webinar. So nephrology is a pretty significant contributor to greenhouse gases in healthcare. In Canada, 3 million dialysis treatments are delivered every year, and we estimate the greenhouse gas emissions impact of hemodialysis therapy at 24 to 65 kilograms of CO2 equivalents per treatment. So on the low end, that would represent 70,000 tons of CO2 in Canada, a huge contributor. And we know that dialysis patients are up to their emissions are 7 times greater than the general population. And in the last couple of months, we've worked a lot with the nephrology team at St. Michael's Hospital, who showed us how it's done. And basically, we understood that the dialysis acid concentrate is used to be delivered in these plastic jugs of 4.5 liters. But those jugs were not entirely used for each dialysis treatment. Often there would be some left, and that would be discarded and therefore wasted. Um, and at St. Michael's Hospital and the kidney care center that they deliver over 50,000 treatments a year, which represented something like 9.5 tons of plastic waste annually. Obviously, huge waste. There's a lot of ways to make nephrology greener. This is my grandma. She had kidney failure a couple of years ago, 10, 15 years ago, maybe. And for several years, she was on peritoneal dialysis and she was receiving those boxes at home with plastic bags with, don't know the name of it, the liquid, but she was basically injecting liquid in her belly at night, with waking up and changing liquid. Really, really, really like time-consuming process, and it was limiting her in her ability to live her daily life. She was not able to go. One of her kids is in the U.S. and she was not able to go visit the kid because it was kind of too much trouble to coordinate the delivery of the system. And my uncle gave her a kidney, and that has really changed her life. And in 2024, I was working in Singapore at the Center for Sustainable Medicine, where I met with a lot of nephrologists who work on decarbonizing nephrology. And at that moment, I realized that actually kidney transplants is the lowest carbon form of kidney care. If you have to get some sort of kidney care, a kidney transplant would be the lowest carbon form, because then you're eliminating all this plastic waste and the electricity used for the dialysis machines. And so that was interesting because in Asia generally and in Singapore, I learned that there was more of a stigma around kids giving their parents kidneys. That was something that parents were not, I was told, were not comfortable accepting. Um, so I'm sharing this story with you because what the folks at St. Michael's Hospital did, I think, is really, really, really inspiring. It's a positive story, clear solutions, clear outcomes in terms of reduced greenhouse gas emissions, reduced plastic waste, reduce spend. So it's good for the three C's, right? For care, climate, and costs. So we ended up filming a bright spot story about this. And I'm going to tell you a little bit about my theory of change around bright spot video. So to me, a bright spot video is a good thing that's happening during a bad time. So and the bad time, I'm talking about climate change here. And these are three stories that I did in Singapore on phasing out desflurane, on mitigating nitrous oxides or laughing gas leaks in hospitals, and a switch from IV to oral paracetamol delivery in that perioperative care setting. And the process of approaching a clinician and saying, "Hey, you came up with a really cool solution. We would like to showcase it." That usually is well received by a hospital, but also kind of like gets them to turn around and be like, oh yeah, of course, like we do great solutions around here. And then that pretty quickly escalates to the director of communications, who then escalates this to the CEO for permission to have a camera crew come in the hospital. And I just love showcasing those stories. I just love going to the hospital, filming those stories and putting them on the internet because people are really proud. And then they want to share it and other hospitals learn about it. And then they're like, oh, why don't we do this as well? Anyways, so I'm sharing here this graph from Dr. Fortin Howard. Basically, I think it's really important to build stories around decarbonizing healthcare systems because too often it's clinicians on Friday afternoon, they have an hour, they're working on decarbonizing something, but they don't really have time. They're not really feeling supported because it's so much work. But when you share those positive stories, which took a long time to come to fruition, then it creates a win, and then a win brings more resources, and more resources bring more hope, and then more hope basically enables us to set bigger targets for ourselves. And it's good to feel supported because there's going to be a lot of barriers and loss and difficult moments when we're trying to make change at this kind of level. And so on that, I'd like to leave you on this 5-minute video that we're going to watch together on the solution at St. Michael's Hospital. And the sound comes in only about 10 seconds into the video. So Sandra and Tipu, if you could give me a thumbs up or a thumbs down on the video sound. Thanks so much.
There's been growing recognition of the significant environmental impact of healthcare, which is actually estimated to contribute 5% of the annual greenhouse gas emissions. Typically, healthcare has always been patient first, environment sort of second, but they actually go hand in hand. And renal disease and kidney disease is actually largely impacted by climate changes. So higher temperatures, warmer climates actually is associated with more kidney disease, as well as kidney stones, for example, that end up impacting the burden of patients that we will see in the future.
Hemodialysis is a life-sustaining therapy for patients with kidney failure. For patients who have kidney failure, blood accumulates with extra toxins as well as extra fluid and unwanted minerals, and it's the dialysis process that helps remove these substances.
However, hemodialysis therapies have a disproportionately high environmental carbon footprint within clinical care, and this is due to the high usage of water, energy, single-use plastics, and consumables like acid concentrate. An average 30 to 50% of purchased acid is wasted every hemodialysis treatment in a single patient or SDS dialysis delivery system.
In a typical setup without the central delivery system, staff members need to carry multiple jugs of acid concentrate from storage area to the dialysis stations to set up for multiple patients. Each treatment can use only, on an average, 275 liters of acid out of 4.5 liter jug, and not to mention other consumables like bags of bicarbonate and blood lines. Due to concerns about infection control, the rest of the acid is poured down the drain.
Currently, discarded acid concentrate enters municipal wastewater systems, which is assumed to be dilute, but we actually have no idea what the ecological impact of all that wasted acid is on our environment.
When we are using central acid delivery system, this doesn't go to the drain. It goes back to the tank and we are using again. We are not wasting even 1 liter of acid during the day or during the month, because whatever is not needed by the machine, it returns to the tank that each acid has.
Since we installed the centralized acid delivery system, or the CDS system, we've been able to save an incredible 95,000 liters of acid per year, which equates to about $85,000 of saving per year in costs across the St. Michael's Hospital, as well as its satellite dialysis units. We've also avoided nearly 9.6 tons of plastic waste being sent to landfills and saved costs in waste hauling processes as well. Based on these figures and further research, the decarbonization and action terms at the coalition has estimated that our CDS, or centralized system, saves 0.5 kilograms of carbon dioxide equivalents per treatment. This is associated with the upstream impacts of manufacturing the acids as well. Switching to bulk purchases also helps reduce the emissions associated with transportation and waste management, which is really important in our society because that's actually where a lot of the impact comes from. Tallying these up, we're saving approximately 28 tons of emissions for delivering over 55,000 dialysis treatments per year just at St. Michael's Hospital and its satellite dialysis units. This doesn't tap into what can be done for Ontario and the country at hand. Providing a CDS system is a win-win for all hospitals. There's savings with cost, resources, space, environmental benefits from the avoided emissions and waste to landfills, which ultimately also impacts our patient because climate change is a health concern. And these efficiency gains will ultimately help hospital staff better spend energy on valuable aspects of patient care. This underscores the need for greater awareness and dialogue regarding its potential role in dialysis practice. Here at Unity Health, there is a commitment to investing in our future. Their sustainability strategy covers energy, redevelopment, procurement, as well as culture and engagement. Sharing our findings today will assist in other programs being able to instigate this change. For all healthcare providers, now it's time for us to make some meaningful change and be more mindful of the care that we're providing.
We are eager to share our knowledge and experience to any hospital across Canada or Ontario.
Thank you so much for listening. And I think those stories are really inspiring because like clearly those guys are passionate about what they're doing and they know what they're doing. And so if you have any stories like this that you'd like to share, please reach out to me. I'm at william@greenhealthcare.ca. We're always looking for, and we don't want to take credit for this. We're just like putting a mirror in front of this and say, hey, look at what you guys did. And we should do this in other hospitals. Back to you, Sandra. Thanks for
Thank you. Definitely. We'd love to amplify the good work that's being done. And I'll actually pass it over to Tipu to talk about glass vials.
Thank you, Sandra. Now let's shift our focus to pharmaceutical packaging. In 2023, the Canadian Institute for Health Information reported that prescription drug spending in Canada reached approximately $42.1 billion. As medication use continues to grow, so does the volume of packaging waste, especially plastics. In the United States, a vendor estimates that around 194 billion plastic pharmaceutical bottles are manufactured annually. And as an extension, these likely end up in landfills, highlighting the scale of the environmental burden. Economically, recent projections suggest that pharmaceutical prescription drug spending could rise by as much as 13% in the near future. When we look at packaging options, plastic bottles are widely used, partly because they're inexpensive to produce. Reusing plastic vials presents challenges in pharmacy settings we found largely due to cross-contamination risks. And the risks are tied to the physical properties of plastic, like Sandra mentioned earlier, just permeability throughout multiple uses. But we didn't stop there. We looked further into the research, and over the past decade, research has explored the possibility of safely reusing single-use vials under controlled conditions to prevent microbial growth. Yet, even with advances in sterilization and quality assurance, concerns around safety and medication integrity remain. That said, there are real-world examples that depict reusable vial systems that work. But in particular, all of these sites have found success by switching to glass vials instead of plastic. Certainly, the trade-off is that glass bottles require more energy to produce and have larger manufacturing footprints. But when we factor in their potential for multiple reuses and amortize that impact over those numbers of reuses, the overall environmental impact improves, making them a more sustainable long-term option. And we are seeing this in practice here in Canada. Two standout examples are Teesdale Apothecary in Nova Scotia and Seasons Pharmacy and Culinaria in Ontario. Both are independently operated pharmacies that have implemented voluntary reusable glass vial programs for their patients and have found success with uptake. Our third example on this slide is a larger scale, it's Cabinet Health from the United States, which offers reusable glass containers for over-the-counter medications, so not necessarily for prescriptions. Their system includes refill packets and child-resistant closures, aligning with pharmaceutical safety standards in the US. Now, together, these cases show that with the right infrastructure and support, reusable vials are both feasible and scalable. So let's explore a model and see how something like this works in practice. A patient will attend a pharmacy and voluntarily elect to participate in the glass vial initiative because they need to pay a deposit. And so there is always an option for that patient to go ahead with getting their prescription in a plastic vial and not undertake that cost. Health Canada has found through research that even a small nominal value can affect a patient's ability to access medications. And so by offering this as an optional initiative, we overcome that barrier. And they receive their prescription then after paying that deposit in a glass vial, which they return for a refund once they're finished. If they do need a refill, they do not get medication in that same vial. They will receive a new vial or a reprocessed vial. All returned vials undergo a standardized cleaning procedure and a scan of the regulatory landscape across Health Canada's Good Manufacturing Practice Guide for Drug Products and the National Association of Pharmacy Regulatory Authorities guidance document for the compounding of non-sterile preparations, as well as looking at implementation success across parts of Canada shows promise through the absence of there being a hard stop against the glass vials. And we continue to explore its widespread feasibility through the form of a business case. Our next steps are to learn from the Canadian expertise that has already successfully undertaken this change and learn from their implementation investments, challenges, and stakeholder navigation, particularly within the regulatory space. And we will then use this expertise to establish a holistic and adaptable implementation framework that we can serve to partner organizations, partnerships with Canadian full-service vendors that we are exploring will help catalyze this change as we continue to seek viable partners. If you are interested in participating in this pilot and exploring how this might look like in your facility, please feel free to reach out. We'd love to share our preliminary work with you and explore if this could be a potential pilot. I will add Sandra and I's email in the chat. And with that, I will pass it back to Sandra.
Thank you, Tipu. So the last packaging topic that we'll discuss today, which also is the highlighted segment for tomorrow's webinar, is one of our fastest developing project at the moment, which is related to switching away from using sterile water that comes in plastic 1-liter bottles and switching to using potable tap water, which is tap water that is safe to drink in gastrointestinal endoscopy procedures. Why? Because these are non-sterile procedures where the endoscopes do not go anywhere that the glass of water that you just drank wouldn't go. And I will save the actual implementation details for tomorrow, but following the footsteps of St. Paul's Hospital in Vancouver, the Ottawa Hospital, and St. Joe's Hamilton, we switched from opening a new plastic bottle for each endo patient to only opening 2 bottles in the morning that get refilled using the tap water in the sink and then recycled at the end of the day. And just from this switch alone, the projected savings are over $9,000 per year by procuring 4,200 plastic bottles less. And the best environmental part of this initiative is that by using tap water, we are completely cutting out the supply chain process of procuring these 4,000 plastic bottles, which is over 1,000 kilograms of carbon dioxide equivalent worth of savings. And this is just from bottle production alone. And it does not include the CO2 emissions that exist during the transportation of the bottles from the manufacturer to the hospital. And this initiative also aligns with the Government of Canada's priorities. This change helps hospitals to reduce costs across operations while becoming more resilient to supply chain challenges. And so with the pilot complete, we are open to new partnerships because nationally showcasing and scaling this economically and environmentally cautious change is a stepping stone for the implementation of further innovative green healthcare initiatives. It was also a project that is quite straightforward to implement, given that there was low resistance due to familiarity of this practice across various hospitals that I've been consulting with that do this when there is bottle shortage. And again, we discuss the implementation of this project in depth tomorrow. So I will be putting the webinar link in the chat as well. And so to conclude, these were just a few examples of ways to reduce plastic waste in packaging. On the first day of Plastics Reduction Week, we highlighted our repository, which is growing every week. And right now it sits at showcasing 41 single-use plastic items commonly found related to packaging in healthcare. So if you have an idea, especially one that we can support the implementation of, just like Tipu mentioned, please contact us. We'd love to speak with you. And at the end of the webinar, I'd like to end it by just highlighting a side of pharmacy that, you know, it's always in the background of each initiative, which is the journey of the pill. And this journey is highlighted through this paper that shows the trip of one medication pill that can travel 63,100 kilometers just to get to its final destination in Southern Ontario. And although we didn't focus heavily on deprescribing or decarbonization during the webinar, these are conversations in our day-to-day work. And this map shows that every action matters, and, you know, where the item is packaged, whether it's in a huge pallet or just in a little pill, they can all have considerable impact. And so with that, thank you for joining the webinar, and we will be happy to answer any questions that you may have.